there is some problem with the live transmission, where it's very a pity that we cannot see the case there. I hope that you can solve the problem. In the meanwhile that I have my presentation, please stop me in case you want to go for the live cases anytime.
Okay.
Anyway, I'm going to speak about our research project that we did 2 years ago about genetic aortic syndrome and endovascular treatment. These are my disclosure. And when we think about genetic aortic syndrome, the typical presentation of these patients are quite young.
هو هناك في القاهرة ما هو بيدخل كل الناس من كل حتة عادي.
Are very quite young patients with disease at the level of the ascending aorta.
خد مني السماعة ده، حد من السماعة ده مش سامع حاجة.
And about this kind of pathologies, it looks pretty clear that the results provided by the ascending open treatment of the ascending aorta offer very, very good results, like this experience single center based on 400 cases. And also if we consider the meta-analysis data about 23 studies on 3,000 patients with very, very good result on the early terms and also in the long term. Anyway, it seems to be clear that for this kind of young patient, there are 4 dogma. The gas patients are always young. The gas patient tolerate open treatment very well, and patient with the genetic aortic syndrome doesn't tolerate at all the Stent-graft. And endovascular therapy cannot offer any kind of long-term results. However, despite we have the solid data about the ascending aorta, we have very few data about the results on the treatment of the descending aorta. For sure, the open treatment, when you have a pathologies of the descending aorta, remain the Crawford operation with a very large exposure that everybody know. And probably for young patient, or for sure young patient, could be a good indication. Anyway, the literature doesn't show very encouraging result about this kind of therapy. And the in-hospital mortality remain almost 20%, quite high. These are the data of 2 centers, and how do you say, the number that we have about this kind of pathology are always very small. We are talking about only 32 patients combining 2 big centers. This type of treatment, differently from the open procedure about the ascending aorta, is associated with a very long post-operative stay within very intensive care of patient is needed, a very expensive treatment also. And if we compare the results that we have at the level of this kind of pathologies for endovascular treatment for other disease, we can provide the exclusion of or the replacement of the entire aorta with a very, very small invasive procedure. Then when we think about genetic aortic syndrome patient, we have to split what is the illusion that we have about this kind of patient and what is the reality. The reality is that thanks to the good result of the open treatment for the ascending aorta, patient get older, and patient has a lot of previous procedure before to be treated at the level of the descending aorta. Open treatment, but this kind of patient seems to be not very well tolerated. And most of the center turn down this kind of treatment and this kind of indication. And this kind of patient tolerates Stent-graft, but the native landing zone need to be very safe, need to be very good selected. This is a kind of patient after open treatment of the ascending aorta that show a very complex anatomical situation at the level of the chest. And there is a multiple previous repair before, and there is anatomical contraindication too. And nowadays, most of the treatment offered for the open treatment, they provide a stent graft too. That is combined and is called hybrid procedure. And this can be a very good landing zone if we consider a possible evolution of the disease below of this kind of level. That's why, with this in mind, we can probably reply to this question very clearly. There is some room about genetic aortic patient. In 2019, they came out a new guideline from the European Society that clear show or cited that open treatment remained recommended as first option, but endovascular treatment need to be considered or can be considered, especially when the redo operation or in emerging setting, an open operation is not possible anymore. In this study, if we look at the literature about Marfan patients, we found out 54 patients treated with endovascular procedure. And at that time, the results were not that good. It was 2011, was 24 patients, and there was a high rate of failure. Ahmed, do you?
We can hear you. Continue.
Yes. This is a review that collected data from 12 different papers, and also in this case, there was only 54 patients. If we looked at our experience in Hamburg, we noticed from the early time that genetic aortic patient compared to the standard population offer very good results. Also in the long term, but also at 30 days time. Last year, we collected all the patients that we treated with Marfan syndrome. And we published this data recently on the Journal of Endovascular Therapy. We had 24 patients, and the mean age was 48. I will say is not that young anymore. And the procedure that we performed was in 17 cases just endovascular. In 7 cases, we decided to do an hybrid approach. Most of the procedure were simple TEVAR, but we have also some fenestrated branch endograft with the iliac replacement too. Very important point of this study was the analysis of where we decide to land. And as you say, the most of time the landing zone is at the level of the hearts in zone 2, and also at the level of the zone 4. Anyway, in 50% almost the population, the proximal landing zone was represented from a diachrone graft. As you probably imagine, at the level of the ascendance was treated after aortic ascendance replacement. What is very interesting about this short series is that in 50% of the population we had a multi-stage approach with at least 2 stages and even 3-stage procedure. That is what really show the kind of pathology that evolve over the time. In the short term, we have very good results with no stroke and no spinal cord ischemia, and very limited early mortality. Nowadays, we have also data about long-term results, like in this patient, show a very good remodeling of the aorta after landing in zone 2 with a TEVAR after Marfan, or like in this patient with 5 years results after TEVAR and fenestrated EVAR. we were able to analyze with a Kaplan-Meier the data, and we found out that we had a mortality of 87% with 4 deaths. Only 2 was aortic related. And again, the reintervention rate was not low. And most of the reintervention rates we were able to show that were related to progression of the disease. If we consider the Loeys-Dietz syndrome, the data available are even rare. This is a case that we decided to treat him with a Herlin-Darros landing on zone 2 and providing a good sealing at the level of the proximal aorta, and distally, we decide to occlude the false lumen, placing a candy plug just above the ciliary trunk. This has remained probably the main critical point of the patient, the selection of the proximal endpoint
conclude because the
landing
session about to
zone
be ended.
and probably landing inside prothesis remain the main.
Giuseppe, please try to conclude because the session about to be ended.
Okay. In the other 8 patients remain the zone 2 also a very good solution. I go fast because I think that we have very short time. And the distal landing zone remain also a very critical point. We don't have to exceed with the oversizing and try to select a low radial force stent. And the third critical point remains the landing on the target vessel and the long-term data. In this case, we decide to use a SEX device with trying to revascularize the intercostal artery. In this other patient, we decide to land above the renal artery because it was too small to be included, and the patient was 41 years old. And we decided to stop the treatment at the level of the renal region, just to avoid and to leave for the future treatment. And in this other patient, we was treated in 2 states in 2019 with a TEVAR and candy plug, and then due to progression, we decided to extend the treatment with an hybrid concept below. These are my conclusions. Aortic disease by gas is a progressive disease and multiple interventions are required. And in this kind of concept, minimal invasive procedure play an important role. And treatment of gas patients should be centralized, and the aortic center should offer all kind of treatment. Thank you very much.